Hello, my name is Callie Higgins, and I will be presenting trends in hospital utilization and outcomes for patients with amyotrophic lateral sclerosis, conducted by myself, Dr. Che Harris, and Dr. Ambry Met. Currently, in the United States, around 30,000 people live with amyotrophic lateral sclerosis, or ALS, which is a devastating neurodegenerative disease causing the progressive deterioration of motor neurons and ultimately the loss of all voluntary muscle function. Beyond the physical severity of the disease, patients and their caregivers can be impacted psychologically, socially, financially, and spiritually, leading to an overall decline in quality of life. There is considerable evidence that palliative care services improve quality of life for patients and families impacted by ALS, but racial and ethnic disparities persist within healthcare and limit access to necessary services. Thus, this study explores whether disparities exist for patients with ALS and whether it affects their healthcare outcomes by looking at demographic and in-hospital outcome differences between those who received and did not receive palliative care services. In order to do this, data were collected from the National Inpatient Sample Database, which is the largest inpatient health dataset in the United States. To identify patients with ALS, the database was searched using International Classification of Disease 9th and 10th edition codes, and further codes were used to identify whether or not patients had received palliative care services. The first part of the study looked at patient and hospital demographics. From 2010 to 2019, a total of 103,088 patients with ALS were identified, and of these patients, 13.4% received palliative care services, while 86.5% did not. Those who received palliative care services were older, more often female, and had similar comorbidity burden and were more often seen at academic hospitals. The next part of this study looked at hospital outcomes. Patients with palliative care services had higher odds for in-hospital mortality. They further had greater hospital charges and length of stay was longer, but these were not non-significant differences. The third part of the study looked at palliative care service utilization over time for patients of different races, finding that there was an increase in rate of palliative care service use for all races of the patient population. We conclude that while there were no racial disparities detected in this population showing progress in the field, other disparities were identified and overall palliative care utilization is low, thus demonstrating a need for a national plan involving multiple stakeholders to address stigma, lack of education, lack of providers, and other critical barriers that may be causing this low utilization of palliative care services. Ultimately, this plan could increase utilization of palliative care services to ensure the field meets the principles of palliative care and serves the growing population in need of palliative care. These are my references, and I will now take any questions.
Thank you very much indeed, Callie, for this. Any questions, put them in on the green section on your sheet. Can I start? I'm interested, there were more hospital deaths in the group having palliative care. And a lot of the argument often is that we would reduce hospital deaths with palliative care. Have you got any feel of why people may have been in hospital and died in hospital?
Right. I think this could be due to the fact that when patients are coming into the hospital, patients with more severe symptoms are the ones receiving palliative care. And while this isn't ideal, I do believe that when patients are coming in and they're closer to death, that's when they're receiving palliative care with ALS. Whereas when patients are coming in with maybe less severe symptoms or less comorbidities, they might not be as inclined to receive palliative care. And this ultimately shows a disparity in this utilization because ideally all patients are receiving palliative care, even if they're not necessarily at the end of their life or necessarily have or at the beginning of their prognosis. You want to make sure that all patients are receiving this care across the entire disease spectrum.
So do you think often the palliative care was very late in the disease progression?
Yes, I think often with ALS, patients are receiving the palliative care towards the end of the disease progression. And ideally, because patients and their caregivers need support throughout the entire disease progression, ideally they'd be receiving it towards the beginning of care, at the beginning of their disease diagnosis as well too.
Thank you. I've got a question. Benzie Luca's put in a question. Were you able to distinguish outpatient palliative care, inpatient palliative care, and hospice?
No. So in this study, we looked at the national inpatient sample. So we just explored inpatient palliative care and not really outpatient palliative care or hospice. And how we determined between hospice and palliative care was using the International Classification of Disease codes. And so we only looked at patients that were coded for specifically palliative care services. And so while we can't distinguish what was done, we can distinguish the codes that was just where you can distinguish which patients were coded to have palliative care services.
And you couldn't look at the timing of how long they'd had palliative care beforehand. That wasn't available.
Right. Since we just used the codes, that was also a limitation of the study, was that we weren't really able to look at the quality of care being received or who was necessarily providing the palliative care services, if it was a palliative care specialist. And so ideally, future research will look more at the quality of care and when the care was provided for how long, and also more like when they were given the care in their disease progression.
Can I ask my usual question? If you could give just one message from all of your study, what would it be and who would you want to give it to?
I think my message would be almost to everybody. And while we can't eliminate health disparities in healthcare today, and we can't create the national plan I discussed in the poster today, I think everyone can work to decrease implicit bias in their life and work to just be aware of our own biases. And because I think that if everyone's aware of it, we can increase communication and we can improve relationships between people to ultimately try to work towards decreasing these health disparities and decreasing, I guess, just disparities in healthcare and in palliative care.
And it certainly seems that the earlier palliative care for people with ALS would be worthwhile and may help reduce the people coming to the end of their lives very ill and into hospital at the last minute.
Right.
Yeah. Thank you very much indeed, Callie.
Okay, thank you.